Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Listeners, welcome to another episode of A Tale of Two Hygienists. This is Andrew, one of the co-hosts, and I wanted to do something maybe a little bit different, a little bit special for this episode. This episode was recorded at Chicago Midwinter, and Amber Riley is a good friend of mine. We work on credits as an examiner together, and she's just a solid hygienist doing amazing things. And she brought some friends with her on this episode, and it just overwhelmingly at the very end, both Mike and I, who ended up helping me co-host, we felt that this is a really special episode, and we couldn't wait for the 2, 3, 4 months before it was going to be released. I think that we really need to get this message out there sooner rather than later. And so because of that, we won't be doing any of our normal things. We're just going to be going ahead and just going right to the interview. So listeners, I also ask you that if you have any questions or any comments, to go ahead and direct them right to Amber. She is anxiously waiting for you guys to contact her, reach out to her, and she can help explain the field a little bit more than we had in this short little 1 hour time frame. It was something where, you know, she spends at least 6 hours lecturing on these types of things, and we try to condense some of it, a very high level overview, in less than an hour. So as you can imagine, there's still a lot more that needs to be explained and discussed, and hopefully they'll be back on another episode with us. But listeners, we hope you really enjoy this one and enjoy your week. Thanks. Hey, Michelle.
Yeah?
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
Welcome, listeners, to another interview. I am without Michelle again. I am all by myself, except I have good old brother Michael with me. Hello, Michael.
Well, hello, listeners. So, yeah, I'm filling in for Michelle again.
Stole your Michael.
It happens. You're used to probably stealing the thunder all the time anyways.
No, Michelle. Never mind. We don't need to get into this. Not in front of our guests right now. We have some really amazing guests tonight, and I want to try and be professional this time about it. So we'll calm ourselves down a little bit.
Well, let's go right into introductions.
So listeners, we have probably one of the best episodes you're going to hear in 2017. So we have Amber Riley here today. She spent all day lecturing today, so we'll try not to take up too much of her time, or we'll give her 3 hours, whatever she wants to do, another 3 hours or whatever. But Amber, thank you for being here, and thank you for bringing some guests. So the topic we want to talk tonight is mostly forensics, but I feel like there is a more clinical term that you guys prefer that we talk about.
Well, the topics that I lectured on today in Chicago was forensic dentistry, and I had a morning session that was 3 hours. The program I presented this morning is called 50 Shades of Green, which, a little pull on a popular title of another type of study, but it basically is just a playing on the many colors of green that decomposing flesh turns into. And but I had a great full classroom, and then this afternoon the kind of a continuance of the same theme was beyond the tag and bag. So it's forensic dentistry beyond the capacity of morgue work. So I talked about dental emergency responders that are available certainly in the state of Illinois and state of California where I live, but nationally, if there is a national-wide health threat, an immediate health threat like a biological attack or a water supply contamination or something like that, we wouldn't have nearly enough physicians or nurses to go around providing vaccinations and inoculations, distributing drugs. And the federal government and several state governments have now recognized that dental hygienists, dentists, dental assistants are qualified individuals for drug distribution as well. So that was a big section of this afternoon's lecture, and it's kind of comes to a surprise actually to a lot of the listeners, and we're thinking, of course, I mean, like in where I practice in California and here in Illinois where we are, dental hygienists are delivering anesthetic every single day, and that might tell you if you can make an alveolar block with a 27 gauge long aspirating syringe, it's no problem to hit a butt or a deltoid
That's right.
with the smallpox vaccine.
That's right.
And although we had to prove that to the state senate and also to hopefully to our national senate and Congress, where we can be a nationalized dental emergency responder, but that's kind of outside of the narrow focus of forensic dentistry that people kind of think of just dental identifications.
I do want to come back to that because I have some more follow-up questions about that whole how that happened. Mm-hmm. Do you mind, before we introduce your guest that you brought with you, let's talk about kind of your journey, your story. So you're a hygienist as well. I'm a hygienist. Mike's a hygienist. We're a hygienist podcast, as you can imagine.
Yes.
Tell it to hygienists. How did all this start? Like, what got you into the profession at the very beginning?
A forensic dentistry or a dental hygiene?
As a hygienist, I mean.
My entry into dental hygiene as a profession, I was actually very much influenced by my hygienist. Growing up, I had seen Mary in Dayton, Ohio for many, many years, and my parents are still loyal patients of that same practice, and Mary has long since retired. I grew up thinking I was probably going to be a nurse, and I was very interested in nursing. Allied health was definitely the direction that I was that appealed to me, and in high school, I was a candy striper. I volunteered at the local hospital 2 nights a week.
Very nice.
As a junior volunteer. So I worked with a lot of nurses, both in recovery, in the emergency room, just kind of assisting, doing whatever I needed was asked. And then after high school, I started working full-time in a family medical practice in the town that
Did you have family in medicine before that?
No family in medicine at all.
So you went from doing candy striping to just right into medicine without any guidance?
I did, in fact.
That is amazing.
That's right.
That is a lot of drive.
And after the 2-3 years of candy striping and then going into family medical practice, I was a billing clerk and a receptionist in a family medical practice. So I'm working with nurses in that capacity as well. And I really began to notice that, in my opinion, I was not seeing a lot of job satisfaction in the nurses that I was working with in multiple capacities of nursing. Mm-hmm. I've seen emergency medicine, recovery medicine, family medicine. These were what appeared to be frustrated, less satisfied professionals. And I began to be concerned that as much as interest I had in nursing, maybe that it was a direction that I wanted to reconsider. I went in for my regular 6-month prophylaxis and checkup with my hygienist, Mary, that I had seen for so many years. And she, in her usual bubbly self, asked me, how's it going? How's college? Because I was enrolled in the local community college in the Allied Health program on the nursing track. And I said, everything's going great, but I got to tell you, I'm a little concerned that maybe nursing isn't the direction that I want to go to. And she said, how so? And I explained those same reasons that I just talked to you about. And she said, Amber, have you ever thought about dental hygiene? And I hadn't. I had not. It had not even crossed my mind. And she said, are you kidding? She said, the hours are wonderful. I've never had a patient die on me. And the pay is comparable. And she goes, and I love what I do. And retrospectively, I got to think then that Mary was about the position in her career clinically there where I am now. So I am going into year 19 of clinical practice. And as I think back, I think Mary was probably at 20 or 21 years in practice, and she loved her job. And she always was that hygienist that had a great personality, was always happy to see you. She was loyal to the practice. There was so low turnover. All the things that I know to look for now is in that practice. And she put that bug in my ear. She said, think about it. Why don't you come in and just stay with me for a half a day or a full day and just follow me around and see what a regular, quote, boring day in general dentistry is like. So I did. I took her up for that. And I had a wonderful experience. And I went in after the end of that clinical quarter at college and asked to change my major path from nursing to dental hygiene. And there was a dental hygiene program also at Sinclair Community College in Dayton, Ohio, which is where I graduated dental hygiene school with an associate's degree. And I lost no time either because all of the same core courses were exactly the same. And it was probably the single best decision I had made up to that point in my life. And I was 19 years old, I think, at that point.
Yeah.
And I have, thanked her a million times over that she made such an influence on my life, because I'm like her. I love what I do.
And I think this is going to be a good time maybe for our listeners to just take a second and think about how many times that we've had that opportunity to teach young people about the profession. And are you that young, bubbly, cheerful person even after being in the field for 15, 19, 25 years? Or are you burnt out? Or are you kind of mopey around because your dentist maybe isn't like your best friend? Or, so really, I mean, we're examples to others. How many times have you asked somebody, what their plans were for college?
Oh, I ask them every day, especially when they're in the 16 to 20 range. And I often even offer that to them to say, hey, have you ever thought about dental hygiene? Or even just if you don't know what you want to do, take the dental hygiene prerequisites, because what they allow they allow for nursing, they allow for radiology. There's so many open paths. Like you had mentioned, you switched from the nursing right into dental hygiene with it not being you didn't lose any time for anything. And
not at all.
So oftentimes I encourage young kids to do that. I said, worst case scenario, go and tell them you want to be a dental hygienist, even if you don't want to. If science and medical and that stuff's where you want to get, it's a great start.
And you said, allied health, and it's fantastic. I know, for us, so Mike and I, kind of our backstory is, I was going to be an oral surgeon, Mike was going to be a periodontist, and we were going to go into practice together, and we were going to, share a building. We had all these plans, and dental hygiene came up, and we took it, and we've been running with it ever since. And, I think also sometimes, when you're a new grad, there's a little bit of, I don't want to say sticker shock or buyer's remorse or whatever you want to say, because you get out and it is kind of hard for your first couple of years because you're not comfortable yet. It has nothing to do with the profession. It has to do with yourself and just being a little bit insecure maybe. But past that, I mean, this is such a wonderful profession. It's just beautiful. And look at what you're doing now. It's maybe a little bit different than the traditional path.
Yes, I mean,
by far.
I still practice 4 days a week in general dental, in a general dental practice. I see 30 patients a week generally. Let's see, 8, 4, 30. Yeah, probably about 30 patients a week. So although the forensics is very interesting, and there is somewhat of, I realize there's maybe a glamorous appeal to it. I still work every day in private practice, just like most of the other hygienists that were in the course today, and the dentists that were in the courses today. And so I really very much relate to what we all, the challenges we do have in day-to-day practice, but also the rewards. And I've been in awful practices where everyone hates everyone. You hate the schedule. You hate the front office. They hate you back. And that's it is miserable, but that would be miserable for anyone.
Exactly.
When you have, a practice that's not functioning. But Mary was, she did me such a favor that I have continued to try to pay that forward through my clinical career by extending the same invitation to any patient that says, I'm interested in what you do, and tell me more about it. And it's very difficult to have a conversation with someone while you're, scaling their teeth. Exactly. But I have always invited them to come in and spend a half a day, maybe just a couple of hours, and get a better feel for it. Or parents will ask me to take some influence over their children and say, guide them into what you're doing. This. But also my reflection, I think, if that they can tell I enjoy my job. Yeah. And if I picked that up about Mary, I knew that she enjoyed what she did. I want to make that reflection to my patients as well, and always just be someone that's available, to help them and guide them. And maybe it isn't for them, because we have all probably worked with hygienists where you wonder, why did you pick this profession? This is so not for you.
Yeah. Oh yeah. Well, there's a draw. There's definitely a draw. Compensation-wise. I mean, it's
absolutely
for the amount of education that we have, and that our job responsibilities are pretty awesome, and the compensation goes along with that. So, maybe let's introduce your guest now at this point.
Well, hello. I'm Sakher AlQahtani from Saudi Arabia, from Ryadh. I'm a consultant pediatric dentist and forensic odontologist.
So you're a pediatric dentist.
Yes.
Tell me about that. So. First of all, maybe if you guys don't mind, I'll kind of go back. So tell me a little bit about the education system in Saudi Arabia compared to what you've talked with your colleagues here in the States.
We have a little bit of a difference because you go into college right after high school, so we don't have a pre-dentistry.
Oh,
so
okay.
it's 7 years all in all, but it's right after high school. And then I did that in Riyadh, Saudi Arabia, and then I went to London, United Kingdom, and I did a clinical master's in pediatric dentistry, and then a PhD in forensic odontology and age estimation. And then so I have a little bit of both.
Sounds like you love education. Sounds like a lot of school.
Well, okay, so when I was listening to Amber and you guys talking about how you love your professions, I was a little bit jealous because, I'm not a big fan of dentistry. So I kind of just stumbled into it.
Yeah.
And not stumbled, but I mean, like, I thought I'd love it, but turns out, I didn't like it much. So I was looking for something, after I graduated from, as a general dentist, I wanted to do public health at the beginning, and then I changed my mind because I wanted to do something a little bit clinical, but I wanted to change someone's life. So I thought maybe pediatric dentistry would be for me because that would, have an influence on those children and change their behavior. Maybe
Sure.
Affect them. And then while I was doing my PhD, I discovered forensic odontology, and I loved that.
Yeah.
And I loved the teaching part, the teaching aspect of dentistry more than the clinical practice. But I found myself more in forensic odontology. But I still practice the pediatric dentistry because that's what pays the bills.
Exactly. So how many days a week do you practice still?
5 days a week.
Still, 5 days a week.
Yeah.
Long hours, short hours?
Long hours because I work in the university and then I work in a private practice as well. It's a different system in Saudi Arabia where the private practice starts 4 to 10 p.m. So I do my 8 to 5 in the university and then I go to the to the private practice.
Wow. Until 10 p.m.?
Yeah.
They're open that
and
late.
Sometimes I judge those parents who bring their children at 9.
Thank you. Yes, exactly.
What the hell?
It's like, be responsible for your kids. Well, they are being responsible, actually, by taking them into the dentist.
Well, usually they're like in a very, very bad state. Usually those parents who come late at night usually are the ones with, the abscesses and all the advanced decay. And they came just because the child didn't let them sleep the night before, not because they wanted, the best for their child. So
right.
They kind of, there's a behavior and attitude problem that you see in those parents. Yes, definitely.
Yeah. Well, it sounds more like emergency medicine or emergency dentistry rather than your
for those types of people who come at 9. Yeah.
Yeah. Mike and I, we both worked in pediatrics for a while. Mike for a lot longer than I did, and I think that was what really drove me out of pediatrics. Now, let me back up a little bit also because we did restorative, and so if you were our dentist and you had 3 operatories with children in it, Mike and I would go do all your anesthetic, and then you would come in and you would prep it, and then Mike would come in and fill it, every single one of those chairs. So you'd be doing exams and prepping all day long. That's all you did. And so Mike and I, we liked it at first, but then our practice had like a bench, kind of like what you guys are sitting on, about that long probably, at the end of the room. And so all the parents would come in all the time. And they're the ones that really pushed me out because I was so mad when they would come in with children that had abscesses or just bombed out teeth. And they would say, well, don't hurt my little Johnny. And I'm like, well, you've been hurting him for the last 3 years. And just little black nubs of teeth. And I'm going to give him one little tiny shot to, 1, get him out of pain, but also 2, so we can try and restore something. And you're going to get mad at me for that? And they would just be irate. And so, it was the parents that really drove me crazy.
Yeah, and take it one step farther. After Andrew left, I got in with the surgery team, and so we would actually have anesthesiologists come in, and we would do like general sedation, and we would restore the whole kid's mouth at one time. And so I got to do that for about 3 years, and same thing. It was just it was treating worst case scenarios, and I thought oftentimes, in my opinion, it was a lack of patient or parent education, not necessarily the child's fault. And so
yeah.
And so that's, so to me, that was kind of, again, what drove me for the longest time enjoying it was, a lot, again, the restorative work first, but then trying to teach the parent, we can't do this again. Like this is it. This is as far as we can go. And unfortunately, there was even times where we even had to, the patients would come back and we'd have to do general sedation again, like within 1 year. And it's just, and that's kind of where it gets real sad. And, I don't want to talk about those cases because that's no fun. But yeah, I mean, it's just amazing to see all that. And really it's about teaching those parents to take better care. And so that's what I stayed in a little bit longer. And I enjoyed that part of it, is saying, hey, let's get on board here and let's figure out how to do this.
So while you didn't really, you kind of said that you don't really care for that part as much, but you really prefer the forensics part. Do you feel like it has to do with like the patient contact time? Like, I feel like a lot of hygienists are introverts. Like, we don't really like talking to people, except for our patients. We love talking to our patients, but like, we're not. Well, I don't know how you do it, but get up on stage and talk to people. But the rest of us, regular hygienists, are like, oh, don't ask me questions.
Well, and especially in pediatric dentistry, you have to be bubbly all the time with the children.
Yes.
And if I hear "Let It Go" one more time, so help me God, and I have to learn all the princesses' names and all the characters and everything.
Of course.
And you have to be upbeat with the child, and then you have to be serious with the parent as well.
Exactly.
So you have a split personality. And
what a complex to have right away.
You have no idea. So forensic dentistry, yes, lets me focus. And the other thing that attracted me more to it is that I'm the only forensic odontologist in Saudi Arabia. I'm the first, I'm the only one.
Oh, nice.
Still. So I have a chance to start something new and maybe change the system a little bit. And there are baby steps, but that's what drives me into it more and more. And especially after knowing, forensic odontology also gave me the opportunity to meet wonderful people from around the world and made great friends like Amber and David here and many more. And with them, we get a lot of ideas. From different countries, we meet like biannually, at least, with like most of them. And we share our experiences and we, get these new ideas. And forensic odontology gave me that opportunity. If I was just doing the pediatric dentistry or just dentistry, I'll be more competitive, maybe.
Sure.
And I'll be more, isolated when I go to meetings. Whereas in forensic odontology, because there's no money in it, it's like more, we want the better for, humanity or better for the profession. So we really discuss things even after hours or even like over a drink or something. And we really come up with new techniques and new ideas to improve this profession. So that's how I love it.
I want to come back maybe a little bit after we introduce David to some job descriptions that are maybe different in the United States or Saudi Arabia and kind of what you actually do when you are asked to work in forensic odontology. But David, let's introduce you first.
Hi, I'm Dr. David Wald, and I practice right outside of Chicago in Bensonville. I have general dental practice, and I've been in practice for 33 years.
I love it.
And it's a comprehensive office in a town I grew up in, so I'm a hometown boy there.
So how did you get into this whole little side avenue? It sounds like it's not a moneymaker. So
it's not a moneymaker. It's driven by passion.
That's right.
And I had a very personal introduction to it. I had a first cousin of mine who drowned in Lake Michigan in the wintertime. And the investigator contacted my office because I was her cousin and her dentist. And they said that we will most likely find her in the spring on the shores in Michigan. And she went in the waters up by Zion and Waukegan area up there. And sure enough, in the springtime, I got a call saying we found a body, and they requested her dental records. I had models on her because I had made her retainers after she had ortho treatment.
Yeah.
And I turned over my records to the coroner in Michigan, and the identification was made with her. And I just was fascinated by it as well as happy I could help out. And I researched it a little bit. I didn't know much about it. And I found a book by Dr. Catone out of Texas. And it was just a little paperback book called Forensic Dentistry. And I bought it and I read it. And it was just appealing to me. But again, I didn't know any formal organizations or much about it. And then the American Dental Association, I believe it was in 2003, had a mass disaster workshop, and I attended that, and I really loved it. And it was a kind of a hands-on disaster training where you went into different teams and stuff. And the director said, "I think you'd be really good at this." I was the team lead for our team at the time, and he said there's a Armed Forces Institute of Pathology class that's taught in Bethesda, Maryland, and he said I would take that class if I were you, and that will get you towards doing something like this, on the side. So I did that.
Amber, you looked surprised when you were telling that story.
I didn't know that story about your cousin.
Yeah, it was very personal, and it was, a shock to our family, but it was something that, you're glad he could help out.
Okay, so let's circle back now then. So, Amber, we'll start with you again. So, your experiences in this field in the United States, what is it, what do you get asked to do? And actually, let me back up. Certifications or trainings, how do you do this?
Training is the word you're looking for.
Okay.
Both as a hygienist, but also dentists. There is a certification for dentists. There is not a certification for hygienists at this time. As a hygienist, the same course that Dave was talking about, the Armed Forces Institute of Pathology, it is a now retired immersion course in forensic dentistry. It's no longer available. But I took that course in 2006. And I was one of 3 hygienists in a sea of about 150 dentists and a couple of MDs. Almost all of them were military, as the name implies, Armed Forces Institute of Pathology. But there was a handful of civilians there. And that was my first exposure to how much of a minority I was going to be trying to find a niche in forensic dentistry as a non-dentist. Mm-hmm. But I was received and treated just with the same parity and equity that any other attendee was. And just as in our clinical practices, a hygienist has a scope of practice that is more narrow than the dentist. And another parallel in forensic dentistry to me as a hygienist is that I am working under the supervision of a dentist. And the dentist and I are working under the supervision of the chief medical examiner. The chief medical examiner is always the boss. Okay. Whether it's one body or 1,000 bodies, wherever those bodies are, the chief medical examiner or the coroner, depending on what the authority is in the state or the county, that's the boss. So even though I make an opinion of a positive identification, or me and my odontologist, who's the dentist, we give an opinion based on supporting criteria that this is a positive identification, or that it's not, that we're positive it is not the person you think it is. Ultimately, it's up to our chief jurisdiction to make the identification. So
let me maybe ask Dr. David real quick. So is that weird for you that you, because in clinical practice, I mean, you are, the buck stops with you. You are the boss. And now you have someone that you are answering to, but you, I mean, I feel like you're very fully qualified in a lot of, with all your education. Is that weird for you?
To work with a hygienist in forensics?
I'm sorry, to work with a chief medical examiner or the coroner to be your boss, to have to answer to somebody at this
point. It's given. We know it when we go into it, and it's their jurisdiction, and they have the final say-so on issuing a death certificate. It's a legal certificate, and it's their job, and we're there to adjunct their decisions, and it is no problem to follow the direction of your coroner or medical examiner, because it's their turf.
I love to hear that. I love that the medical and dental community can come to agreements on something. So that's good.
Yeah, I've participated in 3 counties throughout my career. I started in Montgomery County, Ohio. Then I lived in Kitsap County, Washington, and King County, Washington.
Yeah,
and
Washington.
Now I live in San Diego County, California. Yeah, Washington. And I have always had and witnessed and participated in incredible collusion between my direct authority, which was the dentist, and that dentist collaboration with the coroner or the medical examiner. We understand the system. Part of our training in forensics, certainly a training you don't get in dental school or dental hygiene school, is understanding where your role is in the legal system and understanding where your role is not. And that collaboration is part of that understanding, is that I can certainly give you my educated best opinion based on these parameters, that this is a positive identification of John Doe, but ultimately it's the medical examiner that signs the death certificate.
Well, it almost seems like maybe even, to bring it down to like the hygiene level, it's almost kind of like hygienists working with doctors a little
Absolutely.
bit. Like, we have a doctor that we report to. We still have a patient. We have our part of the practice that we do, but yet at the same time, we still have to, when it comes to the death certificate or treatment planning or whatever it is, that's the doctor's job in order to do that. So I guess I could totally see how that makes perfect sense.
It's very much a parallel to practice, and in one of my lectures, I make some very, very opaque comparisons of antemortem practice, which is the practice that we're all in every day that pays the bills, and postmortem practice. And so much of it, although but state to state to state, a hygienist's scope of practice is very, very neatly defined. In forensics, it isn't. And in some states, a dentist is permitted to do a resection of the jaws, for instance. That's cutting the jaws out of the body for whatever reason, either to make an identification easier. If in California, if it's an unknown person and we don't have any clue yet as to who that person is, before the remains are buried or cremated, we always take the jaws. It's actually in our code in the state of California, but that's not consistent in the other 49 states. So you'll have a scope of practice. I have an incredible amount of training and latitude in the department that I work in. Anything that I'm doing clinically on a decedent is under the direct supervision and allowance of my chief odontologist. So he always knows what I'm doing and when I'm doing it. And we both, again, work under the jurisdiction of our chief medical examiner. But my scope of practice in another state, I'm licensed in 3 states to practice dental hygiene: Ohio, Washington, and California. In Ohio, I cannot do expanded functions. In Washington, I can do expanded functions. In California, I can do expanded functions if I have additional specific training. However, I'm the same hygienist.
Right.
Yeah.
Right.
And when I moved to Washington, I could deliver local anesthetic. Just moving from a state in Ohio where I could not deliver local anesthetic, although you can now in Ohio. But there's much more, I would say there's more latitude in forensics as well. It's not as well defined. Like in this, for instance, a very good friend and colleague of mine who's the just past president of the American Board of Forensic Odontology, chief forensic odontologist for the state of Connecticut. Connecticut does not allow jaw resections.
Interesting.
Yes. But yet in California, they're mandated if the individual's unknown. So you do need to know where you're practicing, what your laws are.
Sure.
But part of that, again, that comes with your training, your mentorship under another odontologist, and what the medical examiner will let you do. It's their say.
But in Saudi Arabia, is it Dr. Sakher? How do you want me to address you? Dr. Sakher?
Yeah.
Okay,
you can
sorry.
call me Sakher.
I missed it earlier. I was like, oh, no. Okay. So in Saudi Arabia, you said you're the only practicing one that, exists. This is a whole brand new field. So you don't have hygienists working below you to help you do this. You're by yourself?
I'm by myself, and I'm struggling to convince the authorities that my profession is important. They don't see that at the moment. And it took me like a while for them to recognize that there is, a place for forensic odontology in their practice, because it's done, but by forensic physicians, like or pathologists, or sometimes without even training in dentistry at all.
Really?
But the forensic, examiner or forensic medicine person will do everything. Will do the dental identification, bite mark analysis. And now I'm introducing this new thing saying, people, you need to be trained, and it's a human right violation.
Sure.
And, I'm getting there, but baby steps. But yeah.
Do you have their equivalent of a chief medical examiner or someone that you would have to report to, like be directly under?
Yeah,
Who
yeah.
is that?
So the system is a little bit different. So we don't have a coroner system. How do you say it? Maybe the equivalent of a prosecutor or something.
Okay.
He would be the one asking for autopsies or not, and then the physician, the forensic people, they would do the autopsies based on the request of that prosecutor, and that prosecutor sometimes is not medically qualified. I mean, he could be like a policeman.
Okay.
Or a lawyer or something.
Interesting.
Yeah, it's very different.
Very interesting.
It's a very different system.
I think.
But you have to report to them, of course. Yeah.
Well, how does that work with jurisdiction? Kind of what we were talking about just a minute ago. With, you can go state by state, and it's just totally different.
County by county.
County by county is totally different.
Can be different.
How does that work where you're at? Since you're basically pioneering all of this.
Yeah. Well, I mean,
you should be careful.
Yeah. No, I mean, because forensic odontology doesn't exist in the system at all. But for the other part, we have the same system all over Saudi Arabia.
Nice.
But forensic odontology per se is not like on paper, and it's part of their routine work. And they just practice it as they are. And if they don't know how to do it, they just don't do it. And they just.
So when you finally get all this accepted by the authorities, that you don't expect there to be any regional counties or state issues.
No, it's nice. Central. Yeah.
And we can learn something from that. It's like, bring that back over here. All right, let's see. Where do we go from here? So tell me then, I guess, you guys are all part of the same association and the same group?
There are several. There's a handful of professional forensic affiliated associations, and all three of us are either a member of all three or two of the three. The open door that I went through initially was the American Society of Forensic Odontology, and that is www.asfo.org. And that is an open association, and it has a very, very low fee enrollment. I think now it's $80 or $85 annually. And we have membership. The majority of our membership are dental personnel, dentists, hygienists, assistants. We also have police officers, pathologists, coroners, death investigators that are also members of the ASFO. Collaboratively, though, it's the oldest institution with a mission towards the improvement and understanding of forensic odontology in the United States. We just had our annual meeting last week in New Orleans, which all of my esteemed colleagues were joining me there from. So essentially, we all really came from New Orleans practically to here right away. And that was also combined with another meeting, a week-long conference of the American Academy of Forensic Sciences, which is aafs.org. And that is an academy that umbrellas all of the forensic sciences. And we have one meeting every year as well. And it's a week-long conference of research presentations, poster presentations, scientific sessions, case reports, collaboration, breakfasts and workshops from 7 o'clock in the morning till sometimes 9, 10 o'clock at night when you put in some of the outside, like bring your own slides. Mm-hmm. There is a young forensic science forum. Mm-hmm. There are undergrad students that are members of this academy. And there's an odontology section, there's a pathology section, there's an anthropology section, there's a general section, question documents, toxicology, law.
Wow.
It's a fascinating week. It is awesome. It is overload. I mean, you are so intellectually flooded by the end of that week. Not just in odontology, which is where we do spend the most of our time. But if there's something interesting going on in toxicology, we will all scoot over to toxicology. Or if there's like a big forensic name, like someone that you would know from media or from television or something like that, and we know that person's giving a case report or giving a breakfast, we all scoot over into that. Like when Dr. Jan Garavaglia, she's a medical examiner in Florida, but she's also a big friend to odontology, and she has done direct training with some of our greatest odontologists that we have in the ABFO. And she's done breakfast lectures for the dental section just on some of her casework as a medical examiner. And it's fun, and it's just so collaborative. The Academy is not all-inclusive. The Academy is a application process. You need to bring education and casework to that table. The ASFO is open for everybody. Mm-hmm. The ASFO is a great way to make your networks, to get your casework. Start making networks with your local authorities, or finding out who's doing what close to you. When you have some years of experience and some immersion training, like Dave and I were talking about, the AFIP, then you take that and you apply to the Academy. The Academy requires references, minimum of a bachelor's degree, references from and within the section.
There's a red flag. Yeah,
I'm like, I'll give you guys a reference if you want, but.
And then, to promote within the Academy, it's attendance and case presentations and publishing and your demonstration of ongoing research and participation in forensic science, whatever your field of forensic science is.
So I guess while this field isn't necessarily a new one, there's new techniques being introduced.
Yeah.
Is that what kind of
we have new materials.
Okay.
We have in even just in very, very grounded worldwide acceptance of the validity of a dental identification, a human identification based on teeth and their dental work. The way that we do it has gotten so much better. From taking analog radiographs to taking a digital radiograph. Almost all of the improvements in clinical dentistry have trickled into forensic dentistry.
Nice.
It's a parallel. Digital radiography in my antemortem practice, digital radiography in my postmortem practice. Although I can rip a person's jaws out, and it can make taking radiographs a little bit easier, but generally it's the same. I'm taking a bite wing, I'm taking a full series.
Yeah.
Charting can be done electronically. In the morgue, we still actually do a paper chart. But because it's a little bit faster, and the only software we have on our laptop is the dental imaging software.
Okay.
And but you can absolutely create an odontogram digitally if you want to bring in a charting software and have it available in the medical examiner's department. Do you guys use digital?
We do. We chart through WinID, so we do.
Yeah. WinID is that is a disaster victim identification software. And we use WinID actually in California as well, but the Department of Justice actually does that for us. We just kind of upload it and send it to them. WinID is it was designed by a dentist, diplomated the American Board of Forensic Odontology, which is yet another ranking of forensic dentistry. There are currently 86 board-certified forensic odontologists in the world. Board-certified.
Interesting.
None of them are sitting on this couch, I'm going to tell you. But I'm very fortunate that my supervising odontologist in San Diego County, Dr. Rick Cardoza, is a diplomat at the American Board of Forensic Odontology.
Nice.
And Dr. Wald, you work under Dr. Denise Merman, or Dr. Denise Merman, and she's a diplomat of the American Board of Forensic Odontology, and that's right here in Cook County.
Yeah, we're out in DuPage, actually.
Oh, DuPage County. Yeah. Thank you. Yeah. But so there are a few, and they're scattered about. It's an incredible amount of work to be qualified to even take that exam. Dave is working towards that right now.
Working towards eligibility to sit for the boards.
Wow. Sounds like a process.
It's been 13, 14 years that he has been working towards having the casework to back him up to sit for eligibility. So it's a big undertaking. So if you meet a diplomat and you have a chance, to work with them, it's a phenomenal opportunity.
It's a passion, and it's something you really want to. It grows on you, as time goes on. So
So tell me about I mean, not to jump too far ahead. I mean, I hate to take up your time. We're like 45 minutes in already. So
Okay.
I mean, I have all the time in the world. I hate to take up all your guys' time.
They had supper already. And they promised that I could eat afterwards. So.
Okay. That was nice of them. I wanted to talk about the cases a little bit.
Yeah.
Because when I came in, I sat for just a little bit of your second part of the lecture, just as you were getting introduced and stuff like that. And you had mentioned that, the big differences between your lectures, and you said you had a bunch of pictures and stuff, and hopefully people would want to still eat lunch or something.
Yeah, this morning's course was very much more clinically focused on forensic dental identification and mass disasters and things like that.
I kind of want to know kind of a little bit about that. I mean, you don't need to get into too gory of details in case someone doesn't want to hear it, but whatever you feel comfortable sharing, that'd be just amazing.
Well, there are a lot of things that a body goes through. There's multiple processes of decomposition, and it begins truly seconds, if not minutes, after the point of death. And I've worked in different jurisdictions where, a water death is far different than a fire death. And if a body that's recovered in water, like Dave was talking about, versus an individual that has perished in a vehicle fire or a structure fire, something like that. So my training encompasses really, I want to say all, but I'm always exposed to something like I would never would have saw that coming type of a thing. Skeletonized remains are actually pretty straightforward. It's skeletonized. They're dry. There's not an odor, and they're easy to work on. They're delicate.
Can I ask you about that, though? I mean,
the odor.
Not the odor.
Oh, yeah. It's a common question.
I really don't care about the odor. No, but the skeletonized remains. So that means they've been decomposing.
Dead quite a while. Yeah.
And where do they come from?
So where I live now in San Diego County, my jurisdiction is all of San Diego County, east and west. And then also if there is an unknown, if there's a John Doe or a Jane Doe that's recovered in Imperial County, which is the county just east of San Diego County, we'll handle that as well. And they bring usually just the jaws over to us from Imperial County. That's the entire border of Mexico and California. So, and the eastern part of California is much hotter and much drier. And your body can dehydrate and decompose very, very rapidly in the summer if you are out in the desert. So we do have a lot of undocumenteds that do come in through Imperial County. Anthropologically, their bones do have a unique appearance as being probably non-white. And so I hesitate to say Mexican because Mexico is a border state too. Mexico has very porous borders to their south, and they have a lot of illegals and undocumenteds coming up from Central America. So, and sometimes they do make it all the way, into Mexico, which is North America, and they keep coming. They come through Mexico and they make it into the United States. It's a traumatic journey. If there is dentistry present, there sometimes is a clinical difference between what I would call Western dentistry and non-Western dentistry. But if we find that on our side, if we find remains on the American side, that individual is treated as if they were American. They're given a full anthropological examination of whatever remains are recovered, a full dental examination, charting, radiographs, and they are put into our system as an unknown person. So we have a very good working relationship, actually, with the Mexican consulate in Tijuana because there are remains. And we lose, or we have missing Americans that are in Mexico or unidentified American remains that are recovered in Mexico. So we need to have that collaboration across the border as well. So a skeletonized remains in the desert, you can get down to bones pretty quick. Insect activity, carrion, birds of vultures and things like that. Other animal activity, larger animals, they will quickly dispose of a body, actually, in the tissue. Often you'll find quickly disarticulated remains. I mean, you'll find a leg here and a leg there because animals have pulled the body apart. Also in the water, especially in salt water, if a body goes into the water and it's full of biology, we have large predator animals in the Pacific Ocean, but also it's really like the lobster and the shrimp. They can take a body down really, really, really quickly.
Really?
I know. You are what you eat. Actually, when I was in King County, when I worked in King County, Washington, that's when I stopped eating shrimp.
Really?
Because our chief medical examiner in King County, and he's still there, Dr. Richard Hariff, wonderful man. Wonderful man. He gave me such an incredible amount of exposure and training and mentorship in forensics. But he called shrimp the piranhas of the Puget Sound.
Oh, no.
So you are what you eat. I'm just saying. For all the Washington listeners.
That's why I don't
Sorry.
swim in the ocean.
Oh, that's funny.
But so you can be skeletonized in the water actually pretty quickly too.
It's very interesting.
Mm-hmm. I had slides this morning. You should have come.
I know. Gosh, that would have been great.
Yeah.
So do you ever get? Gosh, I don't want to be too gruesome about this, but do you ever get remains you talked about odor earlier? It's like I just can't do this.
Well, I've never had a case that just blew me so far away that I couldn't get over it. But water recoveries are very aromatic. They're probably the worst, I would say. Or just some body that's been inside of a closed room or closed container, to use that word loosely, for several days. The body decomposes and putrefaction occurs. Temperature, if it's a hot day, if it's a hot room, individual that dies in their home and is not recovered for 7 or 8 days, the odor is profound. And the dental suite is separate from the main autopsy suite, certainly where I work now, but it was the same actually in King County, because often the dental IDs are on decomps and it will funk up the entire autopsy suite. And in California where we have permission for resection, I'll quickly resect the jaws, and I use that usually just using a pair of Home Depot loppers, and just quickly take the jaws out so that I can put the body back away and just work on the jaws. That helps a lot. If you can not get rid of, but you can take the jaws out because that's what we need to work on and move the body away. But it can be really profound sometimes.
You have to work well with maggots. That's the key.
Really?
Mm-hmm. Yes, because if maggots are present, that body is going to be
And then you have a
aromatic.
whole new...
Because the flies leave eventually when there's nothing else.
I think I'm going to entitle this one, The Flies Leave Eventually.
Yes,
There's
that's
nothing
your take.
else.
That's your zipper there.
Oh, my gosh.
Well, eventually the maggots leave, where they evolve into flies and fly away.
Yeah.
So
Anyone in forensics hates flies. We all hate flies because we know that a house fly either started on shit or on something dead. So
yeah,
so whenever you see a fly, it's got a story
that's why
to tell.
I freak out about flies, too. That's so gross. Ugh. They're so nasty.
I noticed that, in the podcast it was okay to use explicit language. So allow me to be myself.
I really wish Michelle was here because she put you to shame right now.
Good.
At first we thought we were going to be a nice, clean podcast, and I edited every swear word, and then I just got so tired of having to, 12, 15, 18 of them. I'm like, I can't do this anymore. Let's just put this as an explicit podcast, and we're good to go. So as long as I don't use the F-bomb, we're good to go.
Yeah, no problem.
So here's the thing. I have so many more questions. I've been writing questions down. I have almost 2 pages of them. But I think that's not really fair to you. So what I think I would like to do is maybe if we could close this portion, this first step of the pod, hopefully you guys can come back again, by maybe doing a step-by-step of when you receive remains, a high-level overview. You don't need to go into detail. And then I want to also talk about how they can come see you, how they can find you guys, and learn more from you, the experts. Because this podcast isn't going to do nearly the justice. We don't have slides. We don't have any of those things. We also don't have their questions that they would want to ask you. So maybe we can do a step-by-step and then contact information, all that.
Absolutely. So I would say, I won't even kind of go into missing persons necessarily. I will just say unidentified person.
Okay.
So it would start with a phone call from the chief death investigator or the death investigator that's assigned to the remains that were discovered. Remains can be discovered from any number of ways. I mean, someone can just, call for a welfare check on their neighbor that they've not seen in a couple of days. The police respond. They find the individual deceased in their home. A suicide that they've jumped off the Coronado Bridge and the body is seen floating in the bay there, and it's recovered. However the method comes in, we'll receive a call and say that they'll say this is probably going to be a dental identification. Autopsy 99% of the time has taken place first. In a situation where it's not a high profile missing person or something like that. In that situation, sometimes they may want that ID so fast, so right away before they even move the body into autopsy. But generally speaking, we come in very, very, very end. The body's already gone through autopsy and the pathologists are working on cause and manner of death. And then we'll perform a dental examination. Based on the condition of the remains, we will make a resection of the jaw if we need to. And if the body is skeletonized, that's not a big deal because, you can disarticulate the mandible from the maxilla very easily and take the radiographs. We do full mouth photographs, full mouth radiographs, full mouth odontogram. And that information is then uploaded into the first the county and then the state of California's unidentified persons database, which is housed and managed and maintained by the Department of Justice in the state of California. If it's a person that there is a possibility of a presumptive identification, this vehicle was registered to Amber Riley, and this vehicle is engulfed in flames and there's a body inside of the car. It's presumptive to say that that's Amber Riley in the car, but it's not definitive. And it's certainly not a scientific identification because burned remains look nothing like, just charred remains or something like that. And there are plenty of situations where it's a situation of fraud, where it definitely wasn't Amber Riley in the car, and Amber Riley's trying to get an insurance settlement or something like that. Sure. Or I let someone borrow my car and they had a horrible accident and they're the ones in the car and not me. But it's at least an avenue. So if it's an unidentified person with a possible identification, the investigators contact the dentist. If known, based on some of the leads, they'll contact the last dentist of record, get the dental records for us, and then we'll go in and have an antemortem record to make a comparison to. More times than not, we can confirm the identity. But every so often, and I had a case already this year where absolutely everyone was so sure that this was who this person was. And we absolutely, without a doubt, excluded even the slimmest possibility that could be that person based on their dental records.
Really?
Yeah, so every now and then you'll have an exclusion of identity. Say, I don't know who this person is, but I can tell you absolutely with certainty that it is not this person.
So, but how did everyone else think that it was? Like based on what
it was an older cold case, and it was a missing person and a jail cell confession to a snitch. The snitch delivered information saying, that he buried her body here. Well, they did go and found a body buried there, skeletonized remains, and so everyone was believing for sure that it would be this person. So we went in to make a dental identification because we had the antemortem record from a case that was probably 5 or 6 years old, and it wasn't them. So you got to go back to the drawing board. Awesome. And there was a lot of very disappointed police, a lot of very disappointed detectives. But now we know that we have 2 homicides.
That's true.
Yes. Yeah. And that case is still open. It's not, so I can't be real specific about it because it's not been it's still open. It's still under investigation, so I can't use names or genders or anything like that. But yeah, there are times when the forensic dentist and the dental team is actually brought in and we make an exclusion of identity.
As a side note, you mentioned earlier, you guys said you do a full mouth photographs, you do a full mouth radiographs. Where do you picture, or maybe not picture, scanners coming in? Since that's going to be, like the full mouth scanners for like CEREC and things like that.
That's an excellent question.
Like a digital impression, you mean?
Yeah, so like for crown preps and stuff, they do those digital impressions.
Well, now it's getting more and more, yes, into practice, into mainstream practice, because it's easier to store, and it's perfect actually for us, because you will have the digital casts of the mouth for like a long time without having to physically store them. And I don't know. I think in the future it's going to be, in the near future, it's going to be mainstream, and it's going to be useful for us, especially in bite marks, maybe analysis as well, because it is detailed and digital, and you can work with it. But so far, I don't think it's been used fully
forensically, not in IDs, not that I know of. I think the only thing that would be cost prohibitive, because there are a lot of dentists out there that have their own kit. They've bought their own cordless X-ray producing machine. Can't use the name of, but there's only one, and it's really awesome.
Of a traveling person.
Of a traveling person.
The Bedouin.
Bedouin.
And and they're making these major financial investments just to make their forensic application easier. Okay. The scanner, could be cost prohibitive to certainly a lot of jurisdictions.
And maybe even time
it's a
prohibitive
great
too.
idea.
Because you usually have to use some sort of a powder and all these other. It might get messy.
It's no more messy than probably it already is.
It's great for antemortem records, though, because the digital record you can store and keep forever, like Shakir said. So
that's true.
Instead of models on a shelf that you might keep for 7 or 10 years and discard them, the digital record can be pulled up anytime at a dental office or a lab or wherever. So
that's a good point.
It's nice to have it on the antemortem side to compare it to.
That is actually a good idea. This is not even close to being the same, but they have these catalogs that when you go to a hotel room, you're supposed to take pictures of every single angle of your hotel room, and you upload it to the central file. And what that is for is actually for kidnapping cases. And so when they see, someone is being basically trying to be sold for prostitution or whatever, that they can see in the background this one little mark right here, and then they can go find them almost immediately.
Based on a GPS tag
based on GPS tags of the photos that you took as you and I are vacationing or whatever. And so this would be something more of I don't want to say preventive, because that's not a preventive thing, but a cataloging system of sorts.
It's a comparison of databases, you know. So you would have a database of what that hotel room looks like stored somewhere, and you can reference it, pull it up in the database, and do an algorithm to do matches to that database.
Exactly. Gosh, I wish I could talk to you guys for more hours. Let's talk about maybe where you guys lecturing next, or how can they contact you guys? And
next month, I'm lecturing at the Hinman meeting in Atlanta, Georgia.
Next month, this will probably come out after Hinman.
Okay. Today is February 25th, 2017. I'm lecturing forensics in the Hinman meeting, which is March 22nd through 24th, I believe, in Atlanta, Georgia. And that will be forensics. My website actually has my upcoming courses on it. So that is www.decoeducation.com. So it's dental consulting and education, but it's deco.com.
Clever.
And it's easy. And I have the different types of courses that I teach, as well as where I'm going to be lecturing next. So if someone's kind of local to the area and they're interested in the topic or one of the topics, they can certainly reach out to me through the website and say, okay, what are you lecturing at, in Texas or in Louisiana or something like that, and I can fill them in. That's probably the easiest way to reach me would be that. Just shoot me an email through the website.
And then, Doctor, when they're in Saudi Arabia, they can just look you up, right?
Actually, in early March, I'm conducting the first forensic odontology workshop with two of my colleagues, one from Spain, she's Joe at CRS, and one from Australia, Alex Forrest, and we're making history. I mean, like the first ever.
Where's that going to be?
Riyadh, Saudi Arabia.
Oh, in Riyadh. Okay.
Yeah, with the Ministry of Interior Affairs. So yeah, we're going to be doing history.
So stop on by, guys.
Stop
all
on by,
you
guys.
hygienists,
Yes.
go
If
on.
you're in Saudi
It's a
Arabia,
layover.
I love
you're in
it.
the neighborhood. Yes, come on in. 5 to 8 March.
Dr. Wald.
I'm just waiting for Shakir to invite me to his workshop to help teach his class.
That's amazing. Is there any final messages you guys want to leave for our listeners, our dental hygiene listeners?
I'm a member of the Forensic Odontology Working Group in the Interpol. And a couple of years ago, me and two of my colleagues, Joe Atzeres from Spain and Emilio Nazzulis from Italy, had an idea of starting a Forensic Odontologists for Human Rights volunteer group. So, working, pro bono for, preserving human rights, doing what we do. And we presented it in the Interpol, and instantly we had 8 people joining. And since then, we are 47 forensic odontologists from around the world. We have 22 countries. And we're all, offer our services, training, mentoring, or even, for countries who don't have forensic odontologists, we can, go there pro bono. And sometimes countries have only one, as in Saudi Arabia, and some other countries as well. And we have a WhatsApp group between us. And we share information and we support each other instantly. And sometimes we hear about things happening in other countries before it's on the news. And we offer support. That person,
Numerous times.
Huh?
Numerous times.
Numerous
that has happened.
times, yeah. And sometimes the single forensic odontologist in that country would say, what do I do? I mean, who do I contact? And instantly someone from, the other corner of the world would answer with a number and say, this is the person to talk to. And that is amazing. And the people in this group, they all have the same passion to serve this, discipline. And they're there because they want it to be good and they want to preserve the human rights. Doing what we do for identification or age estimation, etc. And we have 3 hygienists in the group.
Yeah.
Four hygienists, yeah. So Amber, Riley, Winnie, Fornari, Tracy, Brookshire, and Jenna Payne.
Yeah.
Yeah. So I'm proud of them. Proud of all of them. And Dave, of course, is a member, and Amber.
Well, I just had a quick thing. Last September, I took a forensic class for a CE class, and so I guess as the normal clinician. I mean, that's pretty much what I do. Is traditional most of the time, some restorative anesthesia. I mean, what can I do on a daily basis to make your job easier?
Oh my God, I can tell you exactly what to do. Record maintenance, record keeping, radiographic technique. Take good radiographs, slow down just a little bit, quality radiographs, and an accurate therapy record, the progress notes. Because not every patient is seen like clockwork, and not every patient has radiographs even on a super routine basis for whatever reasons. Maybe it's not clinically indicated, that they actually have radiographs exposed every 12 or 18 months. But good radiographic technique, and don't get rid of the record. Washington isn't one of them, but there are 16 states in the United States that have a 0 record maintenance recommendation in their state code. The ADA recommends 7 years from the date of last service. Mm-hmm. The ASFO recommends forever to please hold your records. We also recommend the ASFO. We also do understand that people are moving digital. They're and shredding old records and things like that. If you know that the patient is deceased and that they've been deceased for a couple of years and there's not going to be a back insurance claim or something that needs to be validated, of course you can properly dispose of those records. But just because the patient's not been in a couple of years and your state doesn't say that you have to keep the chart, we really strongly recommend you keep the chart because it's possible. It's a slim chance, but it is possible that patient's not been in because they're missing. That patient's not been in because they're laying somewhere unidentified. And that record is going to be requested of you by a diligent death investigator somewhere down the road. Personally, the oldest case that I've worked on was 38 years cold. We made a dental identification based on a retained periapical film from an endodontist.
That's awesome.
38 years, that endodontist kept the PA. But had he not, that individual would still be sitting in California, lying in California in a categorized grave as an unknown. So please keep your records.
Yeah, so I was going to say, for all you hygienists out there, when your lead comes up to you and says it's, we need to work on radiographs, we need to work on our notes or anything like that, there are reasons for it. Even silly things like updating, like when I was in pediatrics, we'd have patients get work, in other places, and then they'd come see us, and then all of a sudden it's like, okay, you're not the same person, and we need to consistently always be updating,
update the odontogram.
And keeping it up,
and you refer a patient out for a procedure, extraction, an implant, an endodontic procedure, and that patient comes back into your general practice. Our death investigators go to the general practice to get a record. So please update your record, even the odontogram, which is not the first line that I look for clinically, but it's in the mix. And if you don't have a radiograph from the endodontist that did the endo, take one yourself. It's important legally as well. Civil litigation is a big part of forensic dentistry, actually. And your record will protect you, or it will sink you. But we want it to protect
Hopefully protect you,
Yes.
And we do reference the written record as often as we do the radiographs, too. The radiographs are pictorial, and it's nice, but we confirm things through the written record as well, so it's important.
His treatment has been completed since the date of the last radiographs were exposed. And so in the morgue, the individual has multiple restorations that are not reflected on the most recent set of radiographs, but the therapy record validates that discrepancy. So, and if you're ever asked to deliver your dental records to a death investigator or a member of law enforcement, give the whole thing over. Make a copy for yourself. Do expect that you'll never see that record again, although a lot of jurisdictions will say, we'll give you the chart back. I've never seen that happen. So do be prepared for that.
Nice.
I got something I think I could add for hygiene, because I'm in a unique situation in my county. My deputy coroner is also an RDH. And,
nice.
and
I love it.
That's something that people just don't have or get. So it's great for me because she's very astute to dental. She seeks dental towards identifications. If she's on the scene, she knows exactly what to look for. If she goes out and gets records, antemortem records, she knows what I'd like to have, and she gets the original records, and she gets everything. Very not nice. Just what the dentist gives her. She asks for.
Yes,
the
you are
original
spoiled,
records.
Dave.
I'm spoiled in the forensic dental field, but it's just a unique thing that she's a deputy coroner, and which is her full-time job. She was a full-time hygienist, and she still does dental hygiene as well. So.
She does. She still subs in hygiene from time to time.
Great.
Yeah, so that's great.
It's wonderful.
It's a fantastic thing.
Well, thank you guys so much for being here.
Pleasure.
Listeners, if you guys have any questions, please contact Amber and let her know.
Absolutely, yes. Sakher, tell them the website where they can learn more about...
It's dentify.me. Dentify, as in dental, but dentify.me. And that's our forensic odontologist for human rights group.
And I'll put that in the show notes so everyone will have a link to that.
Very good.
Awesome. Thank you again. You guys are awesome.
Pleasure.
That was
Thank you.
great.
Thank you for the invitation.
Absolutely.
We're happy to do it. I appreciate my colleagues joining me as well.
Thank you very much.
Thank you.
Thank you.